session. Today we have a special guest. This is Justina Sol, who is an ECMO specialist and specialist in intensive care medicine in Nuremberg in Germany. And she is basically guru of ECLS in trauma currently. So we are very happy to have Justina with us now to let us know something about we usually don't do in our pediatric units. And Justina is adult anesthetist. So Justina, please continue with your presentation. And thank you so much for coming.
Yes, Mirjana, so welcome to everybody. And Mirjana, thank you so much. Thank you again for involving me and inviting me. So I'm really appreciated. And I will also have some data about pediatrics. So it's not only adults. And as you, thanks for your introduction. As you said, I'm adult intensivist but actually we also have provided some analysis from ELSO registry, so I can also present you this data. So for today, our topic is ECLS in trauma, and there is a huge question and a bit provocative question. Is it still controversial? Because I will show you some data from the past and how it was developing in the last years, and how the paradigm change has been provided. So I think it will be quite interesting also for people who are not directly involved to trauma provision. I have no conflict of interest to declare, and so about injury-related deaths, what we know until 2010 worldwide, it's expected that deaths resulting primarily from intracranial injuries and hemorrhagic shock in trauma. So the trauma care has improved worldwide a bit. There are some programs also in developing countries and trauma centers, but people are still dying, and the most feared injuries are intracranial injuries and hemorrhagic shock, so so-called lethal trias, also with hypothermia and acidosis, and once patient survive this primary shock, also after days or weeks, these patients are in danger, and weeks or days later, the deaths mostly result of multiple organ failure or infection. And as you can see here, it's mostly also, this is the picture of the lungs of the patient who died after some weeks of treatment in the trauma care unit. So it's not so easy to treat all these patients. And for this reason, we also asked why ECLS and ECMO, because it's not very typical or usual, and some intensivists also fear to use ECMO with all these potential complications in bleeding patient or brain injured patients. So what we have in the past, since the beginning of ECMO provision in 80 years, the first publications and case series was published in the 19th with case series about 20, 30 patients, and then in after the Caesar trial was published, and also this bleeding management and complication management on ECMO due to centrifugal pumps and less anticoagulation, need for anticoagulation. Since all this improvement has been done, we have had much more publications, and year per year, I will show you in the next slides the development of trauma and ECLS care nowadays. So in the about 5 years ago, my center, I used to work in Bochum, in another center than now, and we provided this outcome measures publication. So we have had about more than 50 patients, and we compared this cohort with cohort non-trauma patient as a single retrospective study, and we find out there is no, so the outcome of trauma patient, even in case of bleeding or another severe complication, is not worse as in the normal cohort, non-trauma cohort. So it should not be considered as a contraindication. And the same conclusion we have had from ELSO registry data. So this ELSO registry cohort, it was the study provided about 2018, and we analyzed the data from the ELSO registry. So as you can see, the diagram, the huge diagram, is the numbers of ELSO ECMO cases in the ELSO registry. So the numbers per year, it's about 2,000 up to 3,000, and the trauma cohort is really a minority. So, but as you can see, in the last 5-7 years, the numbers of trauma patients are increasing in the registry. So since the beginning of ELSO registry until to 2017, we have collected and analyzed about 300 patients. To be exact, it was about 279. So it's amount of at this point, at this time, it was 30,000. So it's less than 10%. But the reasons for this, we have had if only the small group of trauma patients are. There are several reasons. So trauma care is related to the big centers, and ECLS provision is not always associated to trauma centers. And the second reason is that trauma for a long time was considered as a contraindication. Even the first patient, adult patient, was a trauma patient with aortic rupture, but for the long time, because of this risk of bleeding, it was just considered as a contraindication, and people don't use it for trauma. But I will show you that it's changing nowadays. So for this cohort, 279 patients, trauma patient identified and included. The distribution of veno-venous, so the majority of the patient was cannulated veno-venous, and only the small part, about 10% veno-arterial, and for ECPR. The most of patients were supported during the past 5 years, so it was more than 60%. And the survival is more than 70%, the overall survival 61. after discharge from the hospital. So 70% of the patient can be weaned from ECLS. And about the complications, so there are more than 80% of patients experience at least one of the complications which are reported in the registry. It's a lot, but mostly they also inotrope support is registered as a complication. So 44% was on inotropes, on vasopressors, and also about 44% experience acute kidney injury, which is also common even in the patient in trauma, even in the patient is not on ECLS. So acute kidney injury is very, very common in trauma. And bleeding complications, what most of us are fearing of, was registered, occurred in 29% of the patients, and 12 of these experienced cannulation site bleeding. So trauma patients are risk patient, but it's not impossible to have them on ECLS. And the similar complication rates were observed between trauma and non-trauma ECLS patients in the ELSO registry. So we compared both. And as I said, ECMO-related complications in trauma are common. And the bleeding is the most concerning complication in trauma, and it appears that the risk is similar to general ECMO, was also compared. So let us move to the pediatrics characteristics. This was a group from the Gaines-Barbara working group and Christopher Bayer. They also involvement in this analysis, and for pediatrics patients, more than 500 patients were identified. The median age was about 5 years, and the reason why do we have more pediatrics than adult patients, we identified more of them, is that we also included drawing and burns in this analysis. So the majority of patients were male, and also the difference to an adult population was VA support. So it was not so uncommon. It was about a bit more than 50%. So drawing is the most common mechanism for why kids are on ECLS, followed by burns and thoracic trauma. And the complication rates were also high, also about 80%, and most frequent types being cardiovascular, mechanical, and hemorrhagic. So the incidences of complications were similar to those reported in all the ELSO cohorts, and the overall survival was about 55%, which is significantly higher for patients on VV, about 70%, so also compared to adult population, and in VA population in pediatrics, it was about 40%. And so we can conclude that survival and complication rates for pediatric trauma patients on ECMO are comparable to those reported for other indications. And again, trauma should not be considered as a contraindication for ECMO. So I summarized some more publications just shortly about ECLS in trauma. And it was another group, the previous, but the cohort, the ELSO registry cohorts either for adult patients as for pediatrics patients are the biggest, and these groups, you can see the publications, they have some cohorts, but they report mostly about the highest number of the patients was about 50, and there are some more, it's not only the outcome people would like to know and people report, but we also published or can find a publication of bloodstream infection. So once we have more and more experience in this, in the provision of ECLS in trauma, we people and another group started to also to analyze the complication, and also as my group, hematocrit and impact on transfusion in patients receiving ECLS. Indications and outcomes is not the only topic, but we need to know more about the complications, the indications, and epidemiology. So moving to the indications, of course, ECLS and ECMO is a challenge in trauma, and everybody asks, so why ECLS and ECMO? There are such severe injuries and sometimes hopeless situation, like severe lung injury, so we cannot believe those people will survive tracheal bronchial ruptured, unfeasible or harmful ventilation, coagulopathy, hemorrhagic shock, resuscitation, major vascular injuries, bleeding, brain injury, surgery, concomitant surgery, and fracture, infection, pulmonary embolism, and even fat embolism. So at this point, we can also ask, so this past contraindications, maybe they are future indications, as we can see. We can also, why not ECLS and ECMO? Because those patients are young, so they have some more, the body is not affected by comorbidities, and they have more resistance to survive. And in case of severe lung injury, tracheal or bronchial rupture, hypoxemia, we can provide oxygenation via VV ECMO, which works even without anticoagulation. And in case of hemorrhagic shock or secondary hypothermia and any kind of bleeding, what VA ECMO can provide is restoring the circulation, rewarming, and improve the metabolism, pH, and electrolytes. So we should not ask why ECMO, we should ask why not. And for this reason, some societies, and the most important one, American Association of Surgery of Trauma, have released some recommendations for ECMO. So the first one, as we said, not to consider as a contraindication. ECMO can be considered for partial or full support in cases of potentially reversible post-traumatic cardiopulmonary failure. So this recommendation has been released 2019, so it's 1 year ago. And which traumatic diagnosis can be considered for ECMO? The answer is no specific. So there are no absolute indications and no absolute contraindications, despite other than irreversible injury. And as always, individual decision regarding anatomy, physiology, and risk and benefit of ECMO needs to be taken into account. What we always is the main concern and main controversial issue is the traumatic brain injury. It has often been considered an absolute contraindication to ECMO due to the need for anticoagulation. But we know what we know, then given advances in circuit technology and reports of successful ECMO use for up to several days without systemic anticoagulation, this diagnosis as traumatic brain injury should no longer be an automatic exclusion. And also no systemic long-term follow-up exists. The literature confirms that patients with brain injury may successfully be managed with ECLS. And you can see some publication from Würzburg, also from Germany, and some more older. They confirmed also long-term ECLS run without anticoagulation. And there's the next question: what is the appropriate anticoagulation strategy for ECMO in the trauma population? It means the minimal amount of anticoagulation should be used to support the trauma patient on ECMO. And for example, for patients with acute concomitant trauma brain injury, traumatic brain injury, the therapeutic anticoagulation can be safely withheld until bleeding is stabilized. And anticoagulation may be held from up to 5 days to an entire run, so long as there is a minimal evidence of oxygenator clot formation, oxygenator clot formation. So this is about the general recommendations. And we have also another working group in collaboration with Maastricht. And the colleague of mine, Anne Villers, and I, with Roberto Lorusso, we provided a systematic review about all manuscripts we have found describing ECLS management in bleeding conditions. This publication is just submitted to ASIO. So I hope I made the second revision, so I hope it will be published very soon. And what we have found in this systematic review, it was 9 case series about a major trauma bleeding, and 7 case series about bleeding in chest trauma, trachea injury and pulmonary bleeding, 2 case reports and 5 case reports about intracranial bleeding pre-SLS. And this is what we previously have seen also in the ELSO registry. These conditions are very rare, so no center have so many cases to report or to provide any kind of even randomized trial or something like this. So people can only report case series or just case reports because these conditions are not common. And it was our aim providing this systematic review to give some more overview about the strategies, how to manage the patient and the circuit in case of bleeding. So what we have found out is that no heparin or no anticoagulation for limited period of time is possible with favorable outcomes. And also careful titration of heparin to lower targets of ACT or PTT is also possible, and the goal is to provide this careful titration or heparin-free run. Anticoagulation is normalized. And of course, there are some, so people also describe, some authors described acute ad hoc maneuvers like clamping of endotract tube compression of bleeding source, but it's not, you cannot stop the bleeding only clamping the endotracheal tube if the patient is arresting. So ECLS can provide this, can support restoring the circulation, and this is the most important message in this systematic review. And our conclusion was that ECLS may be feasible in bleeding, and it's feasible for temporarily circulatory or respiratory support in patients with refractory hemorrhagic shock, mainly due to pulmonary bleeding. It was the most common, until the bleeding will be controlled, and the control is surgical or with hemostatic supplement. And during this time, the ECLS is restoring the circulation and metabolism, and this is a kind of bridging to stabilization of hemostasis of the patient, or a bridge to the surgery. So if we conclude now, back to our first question, ECLS in trauma, is it still controversial? We can say no. It's no more controversial for pulmonary support if we had the right patient, right timing, and right coagulation, or no coagulation at all, no anticoagulation at all. I'm sorry for this. So ECLS in trauma, is it still controversial? We not sure. In case for bleeding, cardiac support, or ECPR, we are still, we have not such a good data support for this, as reported case series or case reports, but the evidence is still growing. And we can say ECLS in trauma is still controversial. Yes, it's still controversial for traumatic brain injury and burns. So this is absolutely the area we cannot be sure, and the evidence, there is a lack of evidence, even if the evidence is growing and some more publication, some more studies are reported. It's still controversial for these patients. So the next one, what's the future about the ECLS in trauma, and the ELSO role in this? As reported, very compared with the main population, less trauma patients in the registry. And I remember for this publication, the most limitation was to identify the trauma patient in the registry. And for this purpose, because there is no trauma ECD code for this patient. So we just collected ECD code related to trauma, and in this way we were looking for this patient. And for now, after we provided this analysis, there is a new item added to the registry, asking, is trauma the underlying reason for ECLS? And it enables to identify the trauma patient in the easiest way. And the next step will be, and maybe you also have seen some announcements on social media about the trauma addendum for ELSO registry. So there is a need for trauma addendum because we need some more data, trauma-related data, also regarding to anticoagulation and bleeding in trauma. So trauma addendum will be an additional resource to obtain obtain reliable and specific data about trauma patients supported with ECMO, especially regarding the severity and injuries and anticoagulation. And of course, we need more evidence to support this statement. And I hope the trauma addendum should provide it. So on behalf of ECLS in Trauma ELSO working group, we are looking for about 40 ECLS centers to agree on submitting data in the trauma addendum. And for now, we have about 25. So if you know somebody, his center is interested to participate in this project, please contact me on this email account. It will be also added at the end of their presentation. And this is the final story. So I always said any kind of procedure can be considered and a standard procedure if it's achieved in place in Hollywood, and it was this movie Code Black, and they have had one episode about a VA ECMO cannulation for trauma, and it was about the title was Corporeal Form, and they showed the workers stuck under the exploded boiler, and the piece of the metal perforating his heart. And it was a team out of the hospital, and they cannulated this patient out of the hospital. So it was very amazing to see this out of hospital cannulation on the movie. And yes, this is my final opinion about ECLS in trauma, and some more conclusions. So my email address for any questions, and of course I'm happy if you ask me your questions also now. So please ask me, and we can discuss your questions. Thank you for your attention and inviting me.